So now we're going to move on to our McGuire Award. This year, as with previous years, we had nominations come, and you all received emails to ask for nominations. We had a committee set that looked at all the nominations and awarded the award to what they considered the person that should be getting the award this year. So Dr. Arteaga was the chair of the committee, and he will be presenting the McGuire Award.
Thank you. Thank you. The William L. McGuire Memorial Lectureship and Award was established in 1992 to commemorate the significant contribution of Dr. William McGuire to cancer medicine. His research was, he played a leading role in the discovery of the role of the estrogen receptor and assays to measure it, to identify, to tell us about the prognosis and treatment decisions for women with this disease. This award is given annually at the San Antonio Breast Cancer Symposium in recognition of the investigator whose extraordinary and sustained achievements in translational and clinical research have made an impact on the understanding of the pathogenesis and/or outcome of patients with breast cancer, and also at those of risk of this disease. The recipient of the 2022 William L. McGuire Award is Dr. Jeffrey M. Rosen. Dr. Rosen is a Distinguished Service Professor, Vice Chair, and C.C. Bell Professor of Medicine and Cellular Biology and Medicine at Baylor College of Medicine, where he has led one of the premier programs in translational research in breast cancer. He's a former recipient of the Brinker Award for Basic Science from the Susan G. Komen Foundation, the AACR Distinguished Lectureship in Breast Cancer Award in breast cancer research, the Mark Dresden Excellence in Graduate Education Award, and the Barbara and Corbin J. Robertson Jr. Presidential Award for Excellence in Education, illustrating his commitment to mentoring of young trainees in breast cancer research. He's a pioneer in the biology and endocrinology of the mammary gland, and for the past 40 years has made important groundbreaking contributions in areas encompassing the hormonal regulation of mammary gland development, tumorigenesis and milk production, development of animal models to study mammary gland development and tumorigenesis, mechanisms underlying the renewal and differentiation of cancer stem cells, the role of epithelial to mesenchymal transition in breast cancer metastasis and drug resistance, and more recently, characterization of the tumor immune microenvironment associated with different subtypes of breast tumors. Dr. Rosen's career epitomizes the mission of the McGuire Award. Congratulations, Dr. Rosen, and please join me at the podium to receive your award and to deliver your lecture. All the way? Okay. We can fall. Yeah. Thank you. Carlos, thank you for filming. Right, you got it. Thanks. Yes, sir.
So I noticed on the what Virginia was just showing, there's something called oldies but goodies. I think probably my talk should have been under that category rather than the McGuire Award. So good morning. I'd really like to thank ACR and San Antonio Breast Cancer Meeting for this tremendous honor, following in the footsteps of so many previous outstanding recipients, including last year's awardee, Funmi Olapati. This award is especially meaningful because Bill McGuire was a good friend whom I first met when I was a fellow at Vanderbilt almost 50 years ago, and in many subsequent Gordon hormone action and breast cancer meetings until his untimely death. And Bill was always very highly supportive and encouraging of my career. I'd also like to give special recognition to the three individuals who played pivotal roles in my career. Bert O'Malley gave me the opportunity to begin my independent research program when we first started what was then the first Department of Cell Biology at Baylor College of Medicine. Fortuitously, Dan Medina was the sole faculty member left in the old anatomy department when we moved to Houston. And he taught me about mammary gland biology and carcinogenesis and became an invaluable collaborator. Finally, Ken Osborne, who more than 2 decades ago really transformed Baylor College of Medicine by starting the Lester and Sue Smith Breast Center, subsequently building the Dan L. Duncan Comprehensive Cancer Center, as well as, you know, making this meeting the premier breast cancer meeting in the world, which will be acknowledged later this morning. Both Bert and Kent are previous recipients of the McGuire Award, and Dan is a former recipient of the Brinker Award. So this morning, I'd like to discuss some of our studies and those of our collaborators that we've used preclinical models for translational breast cancer research. And I'd like to highlight what I think are some important considerations for using these models. So we think we should use genetically engineered models to test combination therapies and ultimately scheduling of therapeutics in syngeneic models with an intact immune system. We want to test drugs with standard of care therapies for appropriate durations, not just a week or 2 weeks and showing a partial response. And lastly, I think very importantly, it's important to test treatment regimens on both established metastases as well as primary tumors with sufficient tumor burden. That's especially important when you're looking at immunotherapy responses. So we initiated these studies in collaboration with Joe Jerry and Dan Medina, who developed a novel p53 model of mammary tumor genesis, which mimics human breast cancer. These studies were performed in BALB/c mice, which are highly susceptible to radiation-induced breast cancer, by transplanting p53 null cells into the fat pad of p53 wild-type recipient mice, resulting in the appearance of spontaneous tumors between 6 and 12 months. As a member of the NCI Mouse Models of Human Cancer Consortium, we began a long-term collaboration with Chuck Peru to credential these models, as Rick Klausner used to tell us we had to do. And I was fortunate to have one of Chuck's students, Jason Hershkowitz, join the laboratory as a postdoctoral fellow. And we were then able to characterize many of these tumors and compare them to the intrinsic human subtypes, as shown on this slide. And Chuck will be presenting the AACR Distinguished Lectureship today in breast cancer research this afternoon, so I'm particularly happy to have that following my lecture. So while Dan Medina focused his studies on early progression and DCIS in these models, we focused our studies on identifying and characterizing cancer stem cells and treatment resistance. An excellent postdoctoral fellow, Mei Zhang, identified a tumor-initiating population identified by canonical Wnt signaling, and she showed that these cells were resistant to radiation treatment, could be sensitized by targeting the Wnt signaling pathway. These studies were continued by an excellent graduate student, Rachel Atkinson, who serendipitously discovered that mild hypothermia sensitized these cells to radiation treatment. So we took advantage of our collaborations in the Texas Medical Center and Rice University, who had developed optically activated gold nanoshells as a method to rapidly heat cells in order to develop an approach to sensitize breast cancer stem cells to radiation therapy, published in this issue of Science Translational Medicine. While studying canonical and non-canonical Wnt signaling in these models, a postdoctoral fellow, Kevin Rorty, discovered that these models exhibit intratumoral heterogeneity very similar to that observed in triple-negative breast cancer, as nicely illustrated on this slide by the immunofluorescent staining for different basal and luminal markers, as well as a canonical Wnt reporter. Mei Zhang then expanded on these studies to study the communication between the diverse assortment of cells in this tumor ecosystem, which Mike Brooks and Max Wicha, in a very nice commentary on our paper in Cancer Discovery, called tumor Twitter. At the time, I didn't know what Twitter was. I was very excited. I quickly lost my enthusiasm after the next presidential election. While we were studying tumor-initiating cells in our preclinical models, we began a wonderful collaboration with our colleague Jenny Chang to translate these studies to patients and determine that these cells were intrinsically resistant to chemotherapy in some neoadjuvant phase 2 trials. Further characterization performed by Chad Creighton, one of our wonderful bioinformatics collaborators, demonstrated a similarity of the tumor-initiated signature with mesenchymal cloud and low subtype, as you can see on this waterfall plot. And more importantly, this signature was also enriched following both letrozole treatment as well as chemotherapy in the bottom panels B and C. Another important finding from the study was the identification that the resistant cells exhibited a hybrid EMT phenotype, characterized by the expression of both vimentin and cytokeratin, shown in the upper right. And these double positive cells were increased post-letrozole treatment, as quantitated by David Rim at Yale using his Aqua platform, shown in the bottom. About the same time, Sundari Mani and Bob Weinberg's lab discovered that the EMT transition generated cells with the properties of stem cells. And in collaboration, we showed that these cloud and low tumors had a high percentage of cancer stem cells with a gene signature that corresponded to the EMT signature. So after Mani moved to MD Anderson, we began a long-term and productive collaboration. So this led us to hypothesize that this EMT cancer stem cell state is often the default phenotype observed during therapeutic resistance. These are not necessarily equivalent, but they're clearly highly interrelated. So in support of this, in the ongoing Artemis neoadjuvant trial at MD Anderson, patients who did not undergo a complete path CR were characterized by a high EMT, high macrophage phenotype. These studies and other collaborative studies with our colleague Sean Zhang at Baylor suggested an intimate relationship between EMT and the tumor immune microenvironment, which I will highlight later. This led our joint graduate student, Swarnima Singh, to initiate a series of studies using our syngeneic cloud and low gem models, which display this high EMT macrophage phenotype, as illustrated by both the heat map of RNA expression as well as immunohistochemistry. So you can see the high macrophage infiltration by F480 stain. And so in our collaborative studies with Chuck Brew's lab, we observed that these cloud and low tumors were resistant to most conventional chemotherapies, such as carboplatin, doxorubicin, paclitaxel, except for cyclophosphamide. However, this response was really only seen in mice with an intact immune system. So after extensive characterization of the tumor immune microenvironment, Swarnima initiated treatment studies targeting CSF1R in tumor-associated macrophages with a small molecule inhibitor, pexidartinib, along with low-dose cyclophosphamide. And this resulted in long-term regression in 2 of these models after stopping treatment at 1 month, shown in the dotted line. And in our very aggressive gem models, this is very unusual to see any sort of long-term duration after stopping treatment. Using imaging mass cytometry to spatially characterize the tumor immune microenvironment, we observed that these are immunologically cold tumors, as shown with the PBS control. But cyclophosphamide treatment alone resulted in an inflamed tumor with high levels of TAMs, shown in the bottom left. And pexidartinib alone, however, had little effect by itself, but the combination treatment, as you can see in the bottom right, actually showed a marked increase in both CD8 T cells and B cells. So we then employed single-cell RNA profiling to look at the changes in immune cells before and after treatment, which identified an increase in CD8 positive memory T cells in the combination treatment group, as illustrated in this UMAP plot. Furthermore, upon cessation of treatment, when we challenged these mice with fresh tumors, we observed a complete or partial rejection in 70% of the transplants. These analyses also identified a population of activated B cells, and ligand receptor analysis suggested that the CD4 T cells and the CD8 positive activated B cells might interact through a CD40 ligand axis. And furthermore, that the activated B cells after combination treatment were enriched, as you can see in this slide, for antigen presentation. Somewhat unexpectedly, in post-treatment mice, we detected what are known as tertiary lymphoid structures, which are thought to promote an immunotherapy response and mediate the response to checkpoint inhibitors in high mutation mouse models of breast cancer. These were characterized further by imaging mass cytometry, as shown nicely by this image on the cover of Cancer Research this past June. We then did neighborhood analysis in these imaging mass cytometry studies and showed that there were clusters, as shown here in the Tisney plots, confirming the proximity of the CD4 T cells and the CD8 positive B cells and the TLSs. I think while these primary tumor results are striking in our preclinical models, the vast majority of breast cancer mortality is due to metastasis. So we feel it's important to investigate these effects of combination treatment in established experimental lung metastasis models. And we did this using unlabeled cells to avoid introducing foreign neoantigens with things like luciferase or GFP reporters, which is a major caveat with the majority of the published studies of metastasis. Combination treatment, again, resulted in a dramatic reduction in tumor burden and, furthermore, an increase in both CD8, 4, and 8 T cells and B cells, shown in the quantitation on the right. So, while pexidartinib is an FDA-approved drug, reversible hepatic toxicity has limited its use in breast cancer. And accordingly, it was discovered in the I-SPY2 trial and it was discontinued. So therefore, we need an alternative approach to target tumor-associated macrophages. And we were fortunate to have access to a mouse monoclonal antibody directed against CSF1R that's very similar to the humanized version, axatilimab, generously provided by Syndax Pharmaceuticals. And this has not shown any liver toxicity data in phase 2 trials of chronic graft versus host disease. So the mouse equivalent, Syndax MS6352, nicely depleted macrophages. This was actually shown last night in a poster discussion a postdoctoral fellow, Diego Pedrosa, participated in. And he also presented additional results of these studies at his poster discussion session yesterday afternoon. So we then tested these in our models, again, with established metastasis, where we randomized the mice and started treatment at 21 days, and then treated for another month. And again, we were able to show dramatic effects of the combination for a month in the metastatic setting in 2 different models shown here. More importantly, the combination treatment led to a prolonged response following treatment cessation, and that's shown here by the red lines, as well as a partial inhibition of tumor growth when cells were reimplanted in the mammary fat pad, again, as a challenge experiment shown here on the next slide. So these studies were, to summarize, were quite exciting. And I think what we've shown is that targeting these tumor-associated macrophages enhance the efficacy of cyclophosphamide, promotes long-term and durable response in both primary tumors and lung metastasis, and that combination treatments leads to an expansion of both B cells and T cells. I think the identification of TLSs is something that we're very excited about and is correlated with favorable prognosis in the clinic. And we think the treatment leads to B-cell mediated T-cell memory activation, durable triple-negative regression in these preclinical models. Oops, I'll go back a second here. So in collaboration with Sean Zhang and a former graduate student, Paul Kim, we've extensively characterized the tumor immune microenvironment now in over 20 different preclinical models. As already illustrated, some of these were macrophage enriched, as you can see in the F480 panel, while others actually were enriched in tumor-infiltrating neutrophils. And so as you can see in the bar graph, one model, T11, is enriched in macrophages, while 2208 is quite enriched in tumor-infiltrating neutrophils. And these neutrophils were further characterized in an earlier study as bone marrow-derived immunosuppressive granulocytic MDSCs. And these were induced by activation of an mTOR pathway and secretion of GCSF. These granulocytic MDSCs influenced metastasis, regulated the Notch pathway in tumor-initiating cells, as illustrated in this model slide. A surprising finding that's still being investigated in our laboratories was the observation that EMT tilts the balance between TIMs and TINs, both by recruiting macrophages, but also by repelling neutrophils. And understanding this yin-yang relationship, we believe will be important for improving the response to both cell and immunotherapies. So in summary, I've showed you that breast tumors can be classified into two general subtypes, one enriched with neutrophils, the other enriched with macrophages. We believe this is a novel way of subtyping breast tumors based on the immune cell infiltration. We showed that this dichotomy of myeloid cell infiltration is genetically inheritable trait, and specifically the mTOR pathway is a positive regulator, and EMT pathway may be a negative regulator of neutrophil accumulation. We found that the pattern of therapeutic response to immunotherapy follows our breast cancer classification, and showed that both intrinsic and acquired resistance are associated with high accumulation of neutrophils. And lastly, these data suggest that neutrophils may be a critical determinant of sensitivity to immune checkpoint blockade, and combination of checkpoint blockade and methods of targeting neutrophils might improve the overall response. So I'd like to finish now with several illustrations, mainly from unpublished data, but also two published studies, of how we've used these GEM models to study a variety of novel drugs in combination with both chemotherapy and immunotherapy. The first studies were performed by an outstanding junior faculty member in our group, Na Zhao. And with support from Effector Therapeutics, we studied the effect of a translation inhibitor, zotatofin, which is a first-in-class sequence-specific EIF4A inhibitor. Now, EIF4A, as shown on this slide, is an RNA helicase that unwinds the secondary structure in the 5' untranslated region of messenger RNAs to facilitate translation initiation. Multiple oncogenes that contain extensive secondary structure in their 5' UTRs have been shown to require enhanced EI4 activity for translation. Zotatofin is currently undergoing phase 1/2 clinical trials in heavily pretreated endocrine-resistant breast cancer and other solid tumors. So we tested this now in a number of our models, both as single agents and in combination with both chemotherapy and immune checkpoint therapy. And as you can see very nicely on this side, zotatofin synergizes with carboplatin, dramatically improving mouse survival across several different basal-like triple-negative breast cancer models. And doing these studies, we've been able to now identify several biomarkers that we hope will help inform future clinical trials. In collaboration with Trey Westbrook's laboratory, we've used our models to study spliceosome inhibitors. These studies showed very nicely that spliceosome targeted therapies trigger an antiviral immune response in triple-negative breast cancer. And a really nice paper published in Cell with the first author, Elizabeth Bowling, a graduate student in the laboratories. In unpublished data in collaboration with Zi Chen's lab, we've been studying how targeting the endoplasmic reticulum stress sensor, IRE1, which has an RNase activity, with a novel inhibitor, ORAN 1001, may help convert immunologically cold tumors to hot tumors. And so, in extensive studies across multiple independent models, ORAN 1001 sensitizes cold TMBC models to the combination of docetaxel and checkpoint inhibition, as shown here for 3 different models. Again, we hope that these results will help inform our current ongoing SPORE clinical trial with ORAN 1001. And Xi's lab has actually discovered some really novel mechanisms of how this combination works. Lastly, I want to mention a paper that we did in collaboration with people at MD Anderson, with Dan McGrail and Phoebus Lin. As you've heard a lot at this meeting, people usually talk about hypermutation being important for checkpoint inhibition. Well, in fact, their laboratory has shown that replication stress response defects are associated with the response to immune checkpoint blockade in non-hypermutated cancers. And as shown in the graph below, several of our models that I've already mentioned were used nicely to show that this RSRD score predicts response to immune checkpoint blockade in preclinical models, and they validated this actually in a clinical trial. So in closing, I'd again like to thank AACR and the San Antonio Breast Cancer Meeting for this honor. the opportunity to present our work. I especially want to thank the members of my lab, Tori here, and this is a picture taken in front of Good & Company Barbecue. For those of you who come to Houston, I recommend that. And the wonderful collaborators shown here on the right who keep me excited about the future. As I mentioned, I've been doing this now for almost 50 years. I'd also like to thank the patient advocates who have been very important in our work. Finally, I have to acknowledge long-term support from the NCI. As you can see, I've had a R01 that's been renewed now for 46 years, which is not quite a record, but I'm pretty proud of. And the fact that I had long-term support allowed us to do these kinds of studies, most of which were not written in the original grants. And I can't emphasize how important that is if there's anybody here from NCI. Lastly, we've had support from CIPRIT more recently, and we had generous provision of zotatifin and the SNDX drug from both Effector Therapeutics and Syndax, and this has really been critical, and they've been very generous with the supplying these drugs. So this has allowed us, I think, to move our foundational studies, which originally were all based on mammary gland development, into the area of translational breast cancer research. For many years, my program officer at NCI would call me up and say, what are you doing that really has anything to do with breast cancer? So hopefully, she's retired now, but hopefully if she's listening, she will realize that it actually did do something with respect to translational breast cancer research. So thank you very much.
I'll bring you the Q&A.
Oh, okay, good.
We're not anticipating that, but we have time for Q&A.
Yeah, that's good. That's great, because I actually wanted questions. By the way, it's very nice to see a full room at this meeting. It's after a couple of years.
I like your comment about the fact that your grants, you did a lot that you did not propose in the original grant applications. And I like that open-endedness that you have embraced and that NCI has supported.
Yeah, no, it's been really critical, Carlos, to move these things forward.
All right. Well, sounds like
there's someone.
There's one.
Yes.
Microphone number 3. Please identify yourself.
Wendy Woodward, MD Anderson. Jeff, that was amazing as always. We've had lots of chance to talk about inflammatory breast cancer over the years that I've known you. And I just wonder if you want to extemporaneously comment on any thoughts about why there's this robustly E-cadherin positive, terrible breast cancer that has all of this other EMT badness.
Yeah, it's a very good question, Wendy. I think it's such a different disease that it's hard to compare with the studies we've done. By the way, I have to give credit. When Wendy came as a fellow to my lab, she introduced us to the idea of using radiation to do these studies, and we never would have done those without her as a fellow. So I don't really know the answer to that, why there's this. It's called inflammatory breast cancer, but what it has to do with the genotype in those tumors.
Well, you can't retire then.
All right, well, I do think the immunophenotyping and spatial transcriptomics that we're doing now will help inform some of those studies.
Okay, I don't see any more questions. So thank you, Dr. Rosen, for your contributions and discoveries, and we hope best luck with your research, translational research moving forward.
Thank you, Carl.
So now I'd like